Hi, Dr. Mikhael Sebally here, who is a board-certified diagnostic radiologist. He has a fellowship training in MSK, so he knows everything about bones and the musculoskeletal system, and he's going to teach us about adult hand and wrist. So take it away, Mike.
Okay, Katie, thank you. So I'm going to teach you today about adult hand and wrist. These are the objectives. We're going to review normal anatomy radiographs of the hand and wrist, and we're going to go over a bunch of cases that are seen in primary, urgent, and emergency care settings. Anatomy and alignment. This is a PA view of the hand. We check for adequacy, and the things we look for are three things. Number one, we make sure we're seeing all the joint spaces of the interpharyngeal joints and metacarpopharyngeal joints. Number two, we make sure there's no overlap between the phalanges. And number three, we make sure the shaft of the phalanges have similar convexity.
And these are PA, Mike, because the people have their hand flat down on the x-ray table, right?
Exactly.
And shooting from above.
Exactly.
Okay.
Next, we're going to check the lines and alignment on the PA radiograph. We have three lines we draw. Line A, which is a line drawn along the long axis of the second metacarpal, and it should intersect the long axis of the radius. Number two, line B, which is a slight ulnar deviation of the proximal phalanges with respect to the metacarpal bones. And C, which is a line drawn at the distal surfaces of the metacarpal heads of the third, fourth, and fifth rays, and this line should intersect the tips of these metacarpal heads. Lateral view of the hand. First, we check for the adequacy of the radiograph. We check the distal radius and ulna, they should be superimposed. We check the metacarpals, they should be superimposed. And we check the joint spaces of the interpharyngeal joints and metacarpopharyngeal joints, and these should be open. Then we have the oblique view of the hand, and again we need to check for adequacy first. A good oblique view is when there's no overlap between the shaft of the third, fourth, and fifth metacarpal bones. There's no overlap between the second and third metacarpal bones, and there's minimal overlap between the head of the third, fourth, and fifth metacarpal bones.
So about the oblique, can you explain why you get it? So I understand like looking at the hand like this, and I understand why we look like this, but why this like weird turn of it? What do you see better in the oblique that you can't see in the PA?
So oblique has a lot of uses. As you see, oblique is like midway between AP and lateral. And the fact that on the lateral view, the metacarpals are superimposed, sometimes it's tricky to assess the abnormality there. However, if you get the oblique, you have them spread out, but not like in AP, so you can still see the angulation and fracture and abnormalities on the oblique view better.
Great, thanks.
This is an AP wrist radiograph. The number one thing we need to check is adequacy of the image. We need to make sure the distal radius and ulna are not overlapping. We need to make sure the base of the metacarpals that we see and the shafts have similar concavity, and we need to make sure the carpal bones are aligned in AP. Next, we're going to cover the Gilula lines. There are three arcs there that we draw. We call them the Gilula arcs or lines. First arc is arc number one, which is a smooth curve outlining the proximal convexities of the scaphoid bone, lunate, and triquetrum. Arc number two is another smooth curve outlining the concave surfaces of the scaphoid, lunate, and triquetrum. And arc number three is the third smooth curve, and it's outlining the proximal curvatures of the capitate and hamate.
When you're looking at an x-ray, do you actually draw these, or you've done it enough times, you kind of see them in your head, but you recommend that we draw these lines to make sure that the bottom three have a good line, and then the top of the bottom three, and then the bottom of the top two all have good lines, right?
Yes. So you need to draw them because to make sure like you see the lines and you're seeing them as continuous. But as radiologists, because we drew them enough times, so we just look at them and we can eyeball them.
Okay.
This is a lateral view of the wrist. Again, we need to check for adequacy. And on the lateral view, the trick we use is that the anterior cortex of the pisiform should lie between the anterior cortex of the scaphoid and anterior cortex of the capitate. Usually we need it in the middle third of this distance. So oblique view of the wrist, we need to check for adequacy of the obliquity of the image. And we check that by seeing the minimal overlap between the distal radius and distal ulna, and the minimal overlap between the base of the third, fourth, and fifth metacarpal bones. Scaphoid view, as it says, it is a special view to assess the scaphoid bone, and it's taken with ulnar deviation of the wrist to be able to see the scaphoid with no or minimal overlap with the surrounding bones, as you can see on this image. So neurovascular exam of the hand, this is an important thing you should do clinically. As radiologists, the last time we did that was when we were interns. But you should make sure you check the sensation, motor, and vascular parts of the neurovascular exam of the hand. Reading hand and wrist plane films. Remember our 4 Ps, need to check the correct patient, the part is correct, the position is correct, and we need to look for priors for comparison. Next, we assess the image quality. As I said, we need to check for adequacy of the image, rotation-wise, if there's blurring, if there's any motion, and if there's over-penetration. So TBD represents tissues, bones, and distance. This is our systematic approach we use when we assess plane radiographs of the extremities and in MSK radiology.